Welcome to the Deep Dive. Today we're cutting through the noise to bring you what is actually a really uplifting story. We're focusing on the #1 reason newborns end up hospitalized globally. For years, this particular virus felt like this, well, terrifying and almost inevitable winter threat.
Yeah, unavoidable, it seemed.
Exactly.
Yeah.
We are, of course, talking about Respiratory Syncytial Virus, RSV, and our sources today show this pretty dramatic global success story unfolding right now in prevention. It's really driven by some astonishing advancements in immunology. So this deep dive is our shortcut to understanding how communities are shifting, from constant crisis to hopefully sustained protection. Okay, let's unpack this.
Right, and I think if we're going to really appreciate the success, we first have to understand just how dangerous RSV really is, particularly for the smallest patients, infants under 6 months old.
Right?
I mean, for an adult, it's often just a nasty cold, maybe it feels like the flu, but for a tiny baby, it can be genuinely life-threatening.
Okay, so what makes it so much worse for them?
Well, what's fascinating in a grim way is the specific pathology, how it attacks. RSV infects the respiratory tract, right? But when it gets down into those really tiny, small airways, the technical term is bronchioles.
Uh-huh.
It causes this really intense inflammation.
So those little air highways just get completely clogged up almost immediately.
That's a good way to put it.
Yeah.
That intense inflammation leads to bronchiolitis and sometimes directly to pneumonia. You get severe swelling, lots of mucus production. And because a baby's airways are already so incredibly narrow, those tubes just get blocked really, really quickly.
That's structural vulnerability.
Yeah.
Wow. I mean, the impact must be immediate and frankly terrifying for parents.
Oh, absolutely. And the statistics, they really underscore the danger. Look at the U.S. alone. Every year, we see somewhere between, say, 58,000 and 80,000 children under 5 hospitalized because of RSV.
That's a huge number.
It is. But if you zoom in on that highest risk group, infants under 6 months old, it's about 2 to 3 out of every 100 infants in that age bracket who end up hospitalized.
2 to 3%. That's a massive volume of critical care needed.
Exactly. A huge burden on healthcare systems, families, everyone. And, you mentioned symptoms. In the youngest infants, they aren't always what you might expect from just a bad cold.
Yeah, what should people look out for?
Well, we often think of coughing, right? But for a newborn, you really need to watch for things like irritability, poor feeding, maybe wheezing,
Okay.
and critically, apnea, those terrifying pauses in breathing. And of course, the highest risk babies, the premature ones, those with chronic heart or lung conditions, they face the most severe outcomes.
Okay, so the threat is crystal clear.
Yeah.
Terrifying.
Yeah.
But the core of this deep dive, as you said, is shifting from that panic to prevention. Our sources are revealing this, well, pretty revolutionary two-pronged strategy that's quite literally rewriting the rules for protecting newborns.
It really is.
So our mission now is to really analyze the data, see exactly how communities are managing to reverse these incredibly high hospitalization rates. Let's start with phase 1, protecting the smallest patients.
Okay. So the strategy is pretty brilliant because it uses multiple lines of defense. The primary approach, the first line, is all about maternal vaccination.
Vaccinating the mom.
Exactly. Pregnant women are now recommended to get the RSV vaccine, usually between 32 and 36 weeks of gestation.
Okay, late in the pregnancy.
Yes. And the goal is beautifully simple, really. The mother's body produces these powerful antibodies against RSV.
Right.
Which she then passes directly across the placenta to the fetus. So the baby gets this protective immunity built in right from the start.
Ah.
And it's designed to last through their entire first RSV season, that critical first 6 months of life.
So the baby arrives kind of pre-armored, but what if the mother doesn't get vaccinated? Or maybe the baby's born prematurely before those antibodies fully transfer. That protection gap must be a concern.
It is, and that's exactly where the necessary backup plan comes in. And this is where we've seen a huge technical leap. For infants who need that immediate, robust protection, especially those considered high risk, we now administer a single-dose monoclonal antibody therapy.
Monoclonal antibody.
Yeah, basically pre-made antibodies.
Yeah.
It's given right at birth or just as they enter their first RSV season.
And we've heard the names for these manufactured antibodies, nirsevimab or clesrovimab. What makes this new generation so much better? What's the game changer compared to what we had just a few years ago?
Well, the logistical difference is just monumental. Before nirsevimab, the main way to give this kind of passive immunity involved monthly injections, often all through the RSV season.
Monthly shots.
For a baby.
Yeah.
Think about the challenge there. Getting an infant back to the doctor's office for maybe 4 or 5 painful shots during the winter months, compliance, sticking to that schedule. Unsurprisingly, it wasn't always great.
That sounds like a total nightmare for parents, for pediatricians,
Yeah.
everyone involved.
It really was. Nirsevimab just transforms this completely. It's a single injection, one shot.
Just one.
One shot of these pre-made antibodies. And it offers remarkable protection, around 80% effectiveness. And that protection lasts for up to 6 months.
Wow, okay, 6 months from one shot.
Exactly. It simplifies compliance massively, close to 100% for that crucial initial dose. It ensures the infant is protected during their most vulnerable period. This single-shot solution is, honestly, a public health miracle for those high-risk babies, especially preemies or those with existing heart or lung issues.
Okay, this sounds fantastic in theory. Maternal vaccine first, this infant monoclonal antibody as a backup. But does it actually work? Does this protection strategy translate to measurable real-world impact right now?
The answer seems to be a resounding yes. The data is already coming in, and it's not just theoretical. Our sources point to a really critical real-world test case, King County, Washington.
Okay, King County, that's Seattle area, right? But includes suburbs, too. A pretty large area, not just a major city center.
Yeah.
About 2.3 million people.
That's right. It represents a good mix. And they ran a modeling study looking at the 2023-24 season once they really implemented this dual immunization effort.
And what did they find? What did the study reveal?
They reported an initial, get this, 28.6% reduction in RSV hospitalizations among infants under 6 months old.
28.6% already.
In the first season of serious implementation, think about the speed of that. That's nearly a 1/3 drop in hospital admissions for those babies. A huge victory right off the bat.
That initial reduction is massive. So if this strategy gets used even more broadly, the projections, they must be even more compelling.
They are pretty astonishing, actually. If King County and, other similar places can achieve high coverage rates with both the maternal vaccine and the infant antibody, the models project a potential reduction of nearly 69% in hospitalizations for that age group in the upcoming 2024-25 season.
Wow, almost 70%.
Yeah, moving from that 28.6% already achieved towards potentially 70%.
That is the definition of a dramatic public health success story. It really shows this calculated two-layer strategy works exactly where it needs to, protecting the smallest patients and taking serious pressure off pediatric hospitals. Okay, so we focused heavily on infants, which makes sense given the risk, but RSV is also, of course, a really severe threat at the other end of the age spectrum, older adults.
Absolutely.
And here's where things get really interesting in terms of policy differences. If you look at the sources, the vaccination rules for older adults actually vary quite significantly depending on where you live.
Yeah, this variation gives us a fascinating window into how different national health systems sort of calculate risk and decide where to put their resources. We've got reports on standards from 3 major systems, the US, Canada, and the UK.
Okay, let's start with the United States. What's the baseline there? Who's generally eligible?
So in the US, the recommendations are quite targeted. The vaccine is generally recommended for all adults aged 75 years and older.
75 plus.
But they also recommend it for high-risk adults who are younger, specifically age 50 to 74 years.
Ah, okay. So if you're, say, 60 in the U.S., you don't automatically qualify unless you have a specific high-risk factor, like chronic heart or lung disease, a weakened immune system, or maybe you live in a nursing home.
That's right. The general threshold for everyone is set quite high at 75.
Interesting. Why so high?
Well, it seems the U.S. model heavily weighs that comorbidity risk having other health conditions, which statistically really spikes around age 75 and older. So they're focusing the broad recommendation on the most severely vulnerable general population group.
Okay.
What?
But if we connect this to the bigger picture, look across the pond, or just north, Canada and the UK, that standard eligibility age drops quite a bit, doesn't it?
It really does. In Canada, the vaccine is authorized and recommended for all adults 60 years and older, full stop.
60 plus for everyone.
Yes. And they also authorize expanded use for high-risk adults aged 50 to 59, kind of similar to the U.S. high-risk group, but their general population standard starts 15 years earlier than the U.S., and currently it's recommended as a single dose.
15 years earlier. And the rules in England and the UK, they mirror Canada here.
Pretty much, yes. Approved vaccines like the GSK Arexvy and Pfizer Abrysvo are recommended for adults 60 years and older across the UK.
So a clear difference. U.S. generally 75 or plus, Canada, UK generally 60 plus up.
Exactly. And This disparity, it raises a really important question for you, the listener, to consider. What does setting that baseline at 75 imply about the U.S. system's risk tolerance for people aged 60 to 74, especially those who aren't currently labeled high risk?
Yeah, it suggests a different calculation, doesn't it?
Yeah.
Cost versus benefit compared to the UK and Canada, which seem to prioritize broader prevention starting earlier in that senior age range.
It certainly points to a different approach to population health strategy.
But, okay, regardless of the philosophical difference in who gets the shot, is the strategy working for this older population too? Do the sources give us hard data on efficacy in adults?
You do. We're seeing surveillance reports coming out of England for the 2024-2025 season that show concrete, rapid success already.
Okay, what are they seeing?
Well, once vaccine uptake hit about 40% in that eligible older adult group, the 60-plus group, the reports indicate an initial drop of about 30% to 33% in RSV-associated hospitalizations compared to those older adults who weren't yet eligible.
30 to 33% drop, just with 40% uptake. That's remarkable. It's almost exactly parallel to the infant success story in King County.
It is, isn't it? A roughly 30% reduction in hospitalizations in older adults in the UK and that 28.6% reduction in infants in Washington state.
So the combined protection strategy, it's really yielding rapid, substantial success across the whole age spectrum where RSV hits hardest.
Absolutely. If we connect this all back, step back and look at the bigger picture, this represents a phenomenal, incredibly rapid pivot in public health. RSV basically went from being this, inevitable annual threat,
Yeah, just something you braced for.
creating these massive winter surges in hospitals, to something that is quickly becoming manageable, even preventable, through these targeted, highly effective tools like vaccines and antibodies.
So the core aha moment here for you, the listener, has got to be the sheer speed and the magnitude of this shift. We're seeing these year-over-year percentage drops in hospitalization rates.
Real-world impact.
Nearly 30% for two completely different age groups on two different continents.
Right.
And it's immediately measurable. Plus those projections for infants, potentially heading towards a 70% reduction. That is the true power of applying preventative knowledge successfully.
And maybe as a final thought, something to mull over. Look again at those stark policy differences in the adult vaccine rollout. The U.S. generally holding the line at 75 plus for the general population, while Canada and the U.K. start at 60 plus case. Now, this isn't about saying one country is right and one is wrong. It's really about understanding different approaches to public health accounting, you could say.
Different priorities.
Maybe different calculations. The sources suggest the U.S. model heavily weights that severe comorbidity risk, which really kicks in around 75 for its broad recommendation, whereas the UK and Canadian model seem to prioritize a broader, earlier prevention strategy for the entire senior cohort. And that distinction, who qualifies for essential preventative knowledge and tools like a vaccine, it's actually pretty critical for understanding national health priorities and how risk is weighed differently.
A really great point to leave us on that difference between protecting only the most vulnerable versus trying to prevent risk more broadly across an aging population. Thank you for joining us for the deep dive. We hope this knowledge gives you an edge.
Thanks for listening.
We'll catch you next time.